So I'm going to round out this morning's talk and talk about Ghani and Stiletto flaps for first web space reconstruction. And just like Amro showed, this is Paco on the left, myself, and my partner, Dan Zlatilo, who many of you know in Cuba in 2024 for just a wonderful meeting. And like I said in the beginning, I learned so much. It was just incredible to spend time with smart people and spend time operating together, which is something we just don't have the opportunity to very much in the United States anymore. But Paco, my dear friend Paco, in April, he gave a PULM talk. And here's what he said. I don't like the Ghani flap, which is really a modified Buck-Gramco flap that was described in 1998. And Ghani broadened the apex of the flap and increased its length to make it more viable. And Paco said that he prefers the first Palmer intermetacarpal flap, as pictured here, which he has published. Well, Paco, I'm sorry, but you're wrong, right? So I think he is wrong about the Ghani flap. I think he may be right about the Stiletto flap, which we'll mention at the end, but I think he's wrong about the Ghani flap. And as a matter of fact, we love the Ghani flap. So this is in the picture again. This is in Cuba. This is Wilhelm Pondag, myself and Dr. Z, and these are these hats that we had in Cuba. But we do like the Ghani flap. We use it a lot. So for our first space hierarchy in terms of reconstruction, if it's just a little bit narrow, like you see in a type 2 thumb hypoplasia, we still prefer a 4-flap Z-plasty. If you need some sagittal skin, we'll talk about using the Stiletto flap. And then if you need a little bit more skin, we move to a Ghani flap. And if you need even more skin, then it's some type of pedicle flap, either a radial form or a radial form based on its perforators. We're not a big fan of the posterior osseous artery flap. We struggle with that flap. And then if you really need a lot of skin, we're still going to a groin or a paraumbilical flap. I think that is your go-to flap if you need a lot of skin on the arm period. And I think it's even better than a free flap most of the time. As my friend Jim Chang says in Stanford, the great thing about groin flaps and paraumbilical flaps is they survive. Like lifeboats never sink, that's what he says, because they're really reliable flaps. We've done some recently on kids from the Gaza who've had bad blast injuries to the arms, and I just think it's a really good flap. So don't forget about the groin or paraumbilical flap. But here's what Ghani described, Abdul Ghani, who's a great guy. So he took the Buck-Gramco flap, which is kind of just a round flap that you often lost the apex, and he redesigned it to make it wider, and he redesigned this rectangular section that moves more distal. So all this blood supply for this axial flap comes from the base, and at least in our practice, what it's done is we don't lose the tip anymore. We used to lose the tip of the Ghani a lot. I'm sorry, tip of the Buck-Gramco a lot. But since we've changed to the Ghani modification, it's just been more reliable for us. I'm going to show you a couple examples. Now, the Ghani flap comes in all sizes. It comes in big sizes if you need big sizes, or it comes in small sizes if you need small sizes. So what I'm going to show you are two case examples. One where I thought we needed a large Ghani, like for an apron's hand is a classic example, and then one where we needed a smaller Ghani type concept. So this is Shifra. She's a 6-month-old girl with left upper and lower extremity ulnar or postaxial deficiencies. Her left hand has 3 digits, which I'll show you, with absence of the ring and small finger. And the thumb and index have a near complete syndactyly. And already the shortened thumb is pulling the index into flexion. And the left foot has 4 toes. So kind of ulnar deficiency-ish for her. Here's her clinical pictures. So this is her left hand. And if you look at the pictures, what you see is a fairly complete, but not quite complete syndactyly between the thumb and the index finger. You can see the flexed posture because the index being pulled down by the shortened thumb comparably. And you can see there's only 3 digits in total. So what's the plan? I think this is the perfect indication for a Ghani. I really do. I think it's in our hands. This has been reliable. It's maybe different, and Paco can comment on whether he would use a first Palmer intermetacarpal artery flap, but we love the Ghani here. So you bring in the Ghani, or you bring in the relief pitcher. Here's our design. Now, I think when you're spending time on the Ghani, you need to spend time on your design. So if you notice, this is not exactly how Ghani drew it. And often it's not exactly the same. We just modify the Ghani to try and cover as much tissue as possible. So the pre-op planning was to use this large dorsal rotation flap, and then your mirror interdigitating flaps, as you can see dorsal, and then to drive it as palmar as possible to get the best thumb index web space you can. Because remember, for life, we need a thumb and a post. You have to get a thumb away from the fingers so they can post the other fingers. And then the dorsal incision is showing what we anticipated to be Burroughs triangles as we cut out the skin, right? So this was our plan. And we will spend more time than normal going back and forth, erasing the lines, drawing the lines, erasing lines, drawing lines, until we think we have it right. Because preoperative skin design is so important to try and optimize the skin that's available and to minimize the amount of skin graft. So now we've elevated our dorsal Ghani, and you can see what a nice web space it has given you. And you can see on the far right how proximal we've been able to drive the web space. Now, obviously, sometimes you're limited by the princeps pollicis, and you can't go any further than that. But sometimes you can drape over the princeps and even get more. And this is what the hand looked like at the end. Really good web space, minimal. I don't remember if we used any skin graft or not, but that's a good web space. And I think that's a use of a big Ghani that's effective. We did use our Burroughs triangles to further shorten and base the Ghani even more volar, and that's our closure. And to me, that's just a home run. We can just drop the mic. So that's an example of what we call a big Ghani. Now, what about a little Ghani? Little Ghanis are necessary also. This is an 11-month-old boy named Kimbrel. He has some type of inheritable clefting syndrome. There's clefts all through his family. It's never been, it's some weird chromosomal 10. It's not your standard split hand, split foot, but he does have clefting syndrome throughout his family. And he has a complete syndactyly between the thumb and index web space on both hands. There's widening of the index and long finger space because he's using that for prehension. And then both hands, in addition to the complete syndactyly between the thumb and index, show an incomplete syndactyly between the long and ring fingers. So the hands are the same. I'm just going to show you the left hand because it's the same as the right. So if we take a careful look, we can see this syndactyly, obviously, that's complete between the thumb and the index finger. You see widening between the index finger and the long finger because that's where he is holding objects. And you see this incomplete syndactyly between the long and ring finger. That's not problematic, but it is problematic when you're trying to do a big Ghani because your dorsal incision is going to get in the way. So how do we circumvent this? We used a baby Ghani, which is what we call it, right? I'm sure Abdul Ghani would not be happy with this baby term, but it's a baby Ghani. So it's a Ghani-ish flap. And we use mirror interdigitating flaps. And then for the nail fold reconstruction, we love Buck-Gramko flaps. So it's kind of interesting. Buck-Gramko described the original flap modified by Ghani, but these flaps, the nail fold flaps, as you see in the picture in the middle, are still referred to as Buck-Gramko flaps. I think they make really nice nail fold reconstruction. And remember, when you look at syndactyly in the long term, one of the biggest complaints of patients is their nail fold. So I think it's important to bias your flap to get good nail fold reconstruction. So here's our flap elevation. This is our baby Ghani being elevated. We're looking for our neurovascular bundles and our princess pollicis. And then we're going to separate these as much as possible, trying not to sacrifice the radial digital artery to the index, although sometimes you have to sacrifice. And then here's our insetting. We're just going to take a lot of time and try and advance this flap as volar as possible. We're going to do a little bit of a Burroughs on the back of the index finger to cut the skin. And then we're going to inset the flap. And here's the closure. And in the end, in this particular case, we didn't need any skin graft, which I think is pretty incredible, actually. With good nail fold reconstruction on the slide on the left, you see the nail fold reconstructed. And this just looks beautiful to me. So I think it's a good sign with no graft. And I think for me, that's just a celebration. So Paco, I think the Ghani flap still is a really good flap to use. Now, what about the Stiletto flap? It's another really good flap. And this Paco does agree. It helps expand the web space, but it also provides volar thumb skin. So when you need skin in the sagittal plane, this is invaluable. Mary Beth described it with Scotto Ishii, and we use it a lot of times primarily in arthrogryposis or clasped thumbs. And now sometimes once you elevate the Stiletto, It's classically described as coming under the thumb to provide volar skin. Sometimes it needs to be dropped directly into the first web space. It just depends upon where the skin deficit is. You need to watch out for two things. Obviously, the radial digital artery to the index finger and the dorsal sensory nerve to the index finger, along with the princess pollicis. So I guess three things. This is an example. Again, this is a great example of spending time designing your skin incision. So the stiletto typically goes out to the PIP joint. You want to make it as wide as possible, but not too wide so you can't close the deficit. You want to look at all the neurovascular structures, and then you want to swing it to the volar side as you see here. So in this particular arthrogypotic leg thumb, we swung it volar to get volar skin. And as you look at the slide on the left, we also snuck up into the forearm and did a fractional lengthening of the flexor pollicis longus because it was tight. Often once the thumb comes out of the palm, the FPL can be really tight. It needs to be addressed at the same time. Now let me show you an example. This is a class thumb that we did a stiletto flap along with an MP joint chondrodesis. In these real bad class thumbs, tendon transfers are ineffective. You need to do something to stabilize the unstable MCP joint. And our preferred technique is a chondrodesis. Here's our stiletto flap being elevated. Again, and the dorsal incision on the thumb is for MP chondrodesis, preserving the growth plate. Again, making it as wide as possible, but allowing primary closure. This is where we swung the flap into the volar side. And here's our primary closure. 1 or 2 pins is adequate depending on how much rotation you need. And here's the closure. I'm going to show you 2 quick videos here. So this is how we design our skin. And what you're going to see here is we're designing our skin such we can make sure we can close it. This is the flap being elevated and swung into the volar defect. And that's the standard closure, as you see here. So we've replaced volar skin to allow for more thumb extension. Here we've done the MP chondrodesis. Here is our primary closure. And here is the stiletto flap being brought into the wound. And you can see the thumb is much straighter now out of the palm. In general, thumb in the palm is just a bad thing, and that's a good position. And with that, I think that's all I have this morning. It's a quick talk, but it's in defense of the Ghani, and I think the Ghani and stiletto are invaluable for thumb index space reconstruction. Let me stop sharing. Okay, Paco, questions?
This is a short talk, but important talk because these are techniques that you use a lot if you do pediatric hands. So they are very important, very important. And to me, stiletto is wonderful. In fact, I like so much stiletto that I don't use anymore for flap set plastic because the stiletto gives you a more rounded web. It's faster. And I don't do for flap set plastic anymore. Would you agree with that?
No, I like the foreflap for thumb hypoplasia. I'll tell you why. I think that especially you have to do a collateral ligament reconstruction because that the incision along the thumb gives you access to the metacarpal head, which allows you to reconstruct the ligament. So I've never tried a stiletto when I want to reconstruct the ligament. Do you get access to the ulnar collateral ligament of the thumb easily? I'm sure you probably do. You know what I'm asking you?
Yeah. For thumb hypoplasia, I use the stiletto. Not the
and you still get access to your UCL reconstruction or repair. Yeah, I think that's I like the foreflap. I think it works pretty well. I mean, it gives you 150% increase distance, so it's not a bad flap, and it's pretty round too. Let me just emphasize: a 2 flap is not round. A 4 flap is much more rounder. So we don't use 2 flaps because they're ugly. They end up with like a cleft, but a 4 flap gives you a more rounded contour and it increases at about 150%. But I think they're all valuable techniques.
And Scott, regarding the book Bramco Ghani modified flap, are you happy with the dorsal hand scar?
Yeah, I know you don't like the dorsal scar. I'm okay with the dorsal scar. I think what I really like about it, honestly, Paco, is the thumb index web space. And I don't know whether maybe you know, whether your first palmar intermetacarpal flap that you talked about last month, whether that gives you as much breadth and wideness as the Ghani flap, right?
It gives you, but in addition, you can combine it with the snuff box flap from Shen. And if you combine both, you can do really severe contractures with local flaps and no need for IOP or free flaps. This is another. So,
Yeah. In general, I don't like free flaps for first web space. I think there's so many other options that are equally as effective. And if you're thinking, for example, you have a trauma case and you're thinking about coming back and do a toe to hand, I think you need a lot of really good skin. And I think your paraumbilical or your groin flap or your radial artery perforator flap is just a better idea than to do 2 microsurgical procedures in a pediatric hand. I think it just gets too hard. I don't know. Maybe I'm just too simple. I like a really good skin coverage and come back and do a toe transfer when there's adequate pulp.
Let's see if there are questions in the chat. Do you use pseudo kite flap?
Do I use a kite flap?
Yes.
I haven't done a kite flap in years, honestly. It just, and I'm not saying it's a bad flap. It's fallen out of our repertoire. So we don't really use many kite flaps. Do you, Paco or Amro? I don't.
Not for first. No, I don't. And I don't like the kite flap because of the cosmetic thing and it's a hard flap anyway. Because sometimes you have a big vessel, but sometimes you don't have a. Okay, and he said pseudo kite flap. I don't know what is a pseudo kite flap. Okay.
SOTO?
Pseudo kite flap.
I don't know. I'm looking it up.
And I have one question for Kozin, please.
Yeah.
Please, what are the golden time to do a surgery for that patient? Before 1 year or after 1 year?
It's a good question. So the question is when to intervene. So in the case that there's complete syndactyly between the thumb and index, and the thumb is deforming the index, we like to get to it by 6 months, right? Because I think it's just a deforming force, it's going to get worse. In the case where it's not a deforming force, then I'm the opposite. I prefer to wait. So one of my favorite expressions is by Peter Carter, who's with Mary Beth Ozaki. And this is the expression that I say to families when I want to delay the surgery. I says, the hand doubles in the first 2 years of life in size, and then does not double again until you're full grown.
Yeah.
So think about that, right? The hand doubles in its size in the first 2 years of life, and then doesn't double again till you're done growing. If you say that to families, it's almost like a light bulb goes off. They kind of get it. So now for example, I do my pulsations now between 18 and 24 months. I don't do them like Buck Ramko initially said at about a year. I think I'm better at it at 18 to 24 months. I think it's easier at 18 to 24 months. And I think there's less chance of having to come back and do some form of revision for malrotation or something if you wait to 18 to 24 months. So I like to wait if I can. I just think it's easier. But if there's obviously syndactyly between digits of unequal length, like a thumb index, you got to get there by 6 months, I think. Paco, when do you go? Amra, when do you go? Yes, when do you go?
Because of some issue of family years, I am waiting after 1 year, between one and 2 years. Yeah.
Yep.
And I have another question, please. You do X-ray as a routine in your case or not? X-ray to get the planning, to get classification and so on? Or?
Yeah. No, it's a good question. So I don't routinely use X-ray unless I'm confused, unless it doesn't feel right. But I do take a quick X-ray shot once they're in the OR with a fluoroscopy, just to make sure there's no synpolydactyly or something crazy like that. So preoperatively, unless it feels funny, like I saw a kid last week where the small finger felt funny, it just felt too wide. I got an X-ray of the syndactyly and there was 2 distal phalanxes. But if I don't get that, I don't x-ray, but I will often take a quick shot in the OR just to make sure there's nothing unexpected.
Thank you.
Good. No, good question, actually. Well, they're practical questions, right? Because a lot of times you try and get a pre-op x-ray, which is okay, but it's not, it doesn't help you. The child's moving all over the place. It's like what Paco showed with the supracondylar fractures. It's a pseudo AP and a pseudo lateral, and it's just more confusing than anything else.
Super. Okay. So,
What
should
else?
we should we finish?
I think so. It was great. It was a great, it was a great section. It really, I learned a lot. Paco, you want to talk about the next one? Do we have a next one planned?
No, nobody's working. Always the same. So then 2 weeks before the next PULM, I have to find talks.
No, but it was, I mean, it was a good turnout. It was a really good talk. The discussion was great, actually. Yeah. All right. Should we call it quits?
See you next second Sunday of June.
All right. Thanks, everyone. Thanks,
Thank
everyone.
you.
Thank you, Ambro. Thank you,
Thank you so
Scott.
much.
I love you.
Thank you. Thank you. Love you
Ciao.
guys.
Love you too. Bye bye.